about saving your patient's life. So highly, highly recommended to do pediatric advanced life support. Last but not least, we have pre-hospital trauma life support. I know many of us have been requesting us to offer advanced trauma life support for a long time, for quite some time now. But unfortunately, we don't offer advanced trauma life support. We offer a course called pre-hospital trauma life support, which is under the National Association of Emergency Medical Technicians. It is both locally and internationally recognized. Difference between ATLS and PHTLS is that PHTLS is modified for the medic who works in the pre-hospital setup. So we can offer trauma life support. We can offer pre-hospital trauma life support. However, unfortunately, we cannot offer advanced trauma life support. Just something to note. Yes, so apart from that, we also offer advanced clinical ECG interpretation. So perhaps you work in the ward, perhaps you work in ICU, perhaps you work in HDU. You look at patient monitors a lot, but you're not able to understand the clinical significance of what you're seeing. Then advanced clinical ECG interpretation is the course for you. Please consider doing it. We hope to see you in that course. This is where we are based. We are based at 5th Avenue Suites on 8th floor. So this is along Gong Road, just before KNH, this tall building, which houses Pathologist Lancet, or now known as Sarba. Yeah, now known as Sarba. This is where we're located. So 8th floor at Quality Care. In case you have any questions regarding any of the courses that we offer, whether it's basic life support, advanced cardiac life support, pre-hospital trauma life support, pediatric advanced life support, clinical ECG interpretation training, or point of care ultrasound training, we welcome you to visit us and learn more. Having said that, we are very, very glad to have you today with us. This is our website. This is our Facebook page. If you've never heard of us before, or possibly this is the first time we are interacting with you, we would request that you check us out at Quality Care Kenya. Quality Care Kenya on Facebook and on Instagram. In case you see a friend or a colleague shining, doing their basic life support, shining, doing the advanced cardiac life support, shining, doing the pre-hospital trauma life support, or whichever course it may be, we request that you please follow us and say you found us from the trauma life support webinar. So having said that, now I would like to hand over the stage to Eric Menya. He'll be taking us through the session today. In case you have any questions, the chat is open. The chat box is open. My name is Edgar, admin at Quality Care. This is my number in case you have any questions regarding any of the courses we offer, or in case you have any questions regarding CPD points, which I'm sure after the course today, many people will be wanting CPD points. Having said that, karibuni sana. I hope the session will be interactive. Yes, the chat box is open. I know we are not able to unmute, but whatever questions you may have, please share in the chat and we'll be able to respond. So just a minute as Eric sets up, we'll be starting shortly.
All right. Okay. So good evening, everyone. Happy to be here today. We will uh, discuss trauma. And before we start the discussion on trauma, one of the things that we must acknowledge is that locally here in Kenya, we actually don't have trauma centers. So because we do not have trauma centers, we have tried to look at or create a presentation that caters to in-hospital and pre-hospital and tries to like sort of give you a feel of what you would do if you find yourself in an ill-equipped setting. You're ill-equipped to provide definitive care in terms of not having the specialties, in terms of not having the necessary equipment in order to provide the service that, okay, just a minute. We All right. So because of time, we will just get straight into it, and I will sort of um, try and summarize so that we are able to um, so allow us to extend by 10 minutes so that within the next 35 minutes, we try and discuss the systematic approach to trauma. I know some of us already have a clue about it, but bear with us because of time, we likely will not get to discuss the actual management, or we will try and highlight some very key things that we can do in case we come across a trauma patient. Now, trauma deaths usually occur in three peaks. Okay. So there's the primary injury. The first peak essentially looks at the primary injury. The impact has occurred or whatever it is has happened. And this death is usually as a result of severe brain injury, a high spinal cord injury, resulting in things like respiratory arrest, leading to then cardiac arrest, rupture of the heart or rupture of the aorta or large blood vessels, and thereby massive blood loss. Now, this first peak, intervening for this first peak is hard. Okay, typically, even with the best pre-hospital care, individuals are unlikely to survive following the first injury if it's a major injury within the first peak. So most first peak injuries result in death. Now, the only thing that we are likely to achieve in order to help with the first peak is maybe preventative measures. So say road safety, if we are talking about people working in a construction site, basic safety measures, so helmets, these are things that if for those of you who will venture into occupational health and safety, those are things that possibly you can do something about. So in terms of first responders or medical practitioners providing care in a healthcare facility, there's not much we can do about the first peak. The second peak usually occurs within minutes to hours, and this is actually the primary focus of the initial assessment and the initial care, and it will be the primary focus of what we are discussing today. Okay, death usually occurs within minutes to hours. This death is usually due to one, catastrophic hemorrhage. So in pre-hospital terms, we call it exsanguinating hemorrhage, typically from a large artery. Exsanguinating hemorrhage is likely to kill your patient within 2 to 3 minutes. So whenever the patient is exhibiting signs of exsanguinating hemorrhage, significant hemorrhage, we call it catastrophic hemorrhage, then that is the priority. So the initial assessment tries to empower you to sort of prioritize your care. So we are saying catastrophic hemorrhage will kill your patient first, okay, within 2 to 3 minutes. Now, injuries to the airway or a compromised airway, let's say our patient has suffered a TBI. As a result of the TBI, this patient has then developed a compromised airway. If we don't relieve the airway compromise, or maybe they have suffered a respiratory arrest due to a high spinal cord injury, the respiratory centers are affected due to a TBI, then this patient will die as a result of airway compromise or breathing issues within 4 to 6 minutes. So within 4 to 6 minutes, they are likely to suffer irreversible brain damage and possibly death. All right. The next thing that is likely to kill your patient, so a hemopneumothorax or a tension pneumo would also affect your airway, your breathing or ventilation. So that would also fall under that category. Now, shock is also likely to cause death within minutes to hours. So any significant injury, whether it is internal, leading to significant blood loss, is also a priority, be it pre-hospital or in hospital. This then means that what we have discussed is that basically airway, breathing, circulation, and disability under the second peak. So disability as your TBI, airway and breathing as your other things, and then catastrophic hemorrhage as part of circulation, essentially. The third peak is as a result of the sequelae or the things that then occur following this traumatic injury. So these traumatic injuries have not been addressed adequately or correctly, then death is likely to occur within several days to weeks. This could be due to sepsis or multiple organ system dysfunction. So perhaps during the initial hour, our patient lost a lot of blood volume, and as a result of that not being resolved in time, the patient then developed acute kidney injury, and then other things then set in. So these are things that will then kill your patient within several days to weeks following the traumatic incident. This then emphasizes the need for coordinated care, whether pre-hospital or in hospital. Now, rapid assessment and resuscitation is therefore key to the survival and the outcomes for the patient, not just within the second peak, but also within the third peak, in terms of us being able to save organ and limb. Okay, so appropriate and timely care will significantly improve your patient outcomes, making that initial assessment and management very important. Now, currently in our setting, we are saying we don't really have trauma centers. So that's a limitation because definitive care ideally is usually, so we are looking at the US setup. Most of the time, definitive care will be available at regional trauma centers or level 2 and level 1 trauma centers. Now, in our setting, definitive care will only be likely available at a level 5 or a level 6 setting. Now, sometimes even the level 5 will not really have the capacity to handle trauma. Okay. The second limitation, which is something we can do something about, is the capacity to recognize the extent of patient injuries in good time and determine whether or not we are able to manage those injuries within our setting. Okay, so we all know where we work and what we are capable of doing. The next limitation is the scope of practice and the equipment that you would have available. This is particularly in the pre-hospital setting. Remember, the emergencies will likely that you will likely attend to pre-hospital will find you not really in the mood or in the setting to provide care. So here I'm talking about you're on your way home, possibly, or for those who work in a pre-hospital setting or in a field setting, you will lack the scope of practice most of the time or the equipment necessary to effectively and definitively manage your patients. Now, what must we do then, even in our current situation where majority of us would be ill-equipped? So we need to prioritize care. As I had said, we should assess the patient in a way to identify the most immediate life-threatening injury and attend to it to the capacity that we can. Transport then must also be prioritized and initiated as soon as we identify the need for the definitive care. So you've done your primary assessment, you've reached disability, and your patient is showing signs of herniation secondary to a traumatic brain injury, and you are at a level 4 trauma center, you need to prioritize transporting this patient to a facility that can effectively handle a TBI patient. So this is a facility that has neurosurgical capacity and has 24/7 specialist care. Okay. We also need to ensure a complete assessment to identify all injuries. This may not be possible on scene. So at times, as soon as you identify a life threat that you can't handle, prioritize referring this patient. Now, what are your priorities of care? A trauma patient has come into your casualty. First of all, of course, scene safety, your safety, of course. Okay, so in the ED, then scene safety is not that big of a deal, but out of hospital, that would be a big deal. So what you then need to ensure is you have your PPEs on. So what is standard within your facility? So you need to have protocols in place outlining what is standard for a trauma patient. So we are saying something to protect the mucous membranes, the eyes, so a mask, possibly a face shield, a gown, yeah, gloves, all those aspects. Once you are adequately protected, then you need to identify whether or not there's a need for additional resources. Now, most of the time, this takes the form of how many casualties have you received? Okay, so number of casualties can determine the need for additional resources. The nature of the injuries can also determine whether you need to ask for additional resources. The mechanism of injury, you must find out what is the mechanism of injury, okay? Because this then determines the kind of injuries you're likely to be dealing with. A fall from height, the moment I get a history that there's a fall, or a report that it's a fall from height, then I'm suspecting possibly there could be a traumatic brain injury. Possibly there could be a spinal column or a spinal cord injury. Possibly there could be long bone fractures. Possibly there could be what do you call it? A pelvic fracture. Okay. If I get, say, a head-on collision, then possibly there could be thoracic injuries. So the mechanism through which the patient got injured is very, very important for you to establish early so that you are already thinking of the kind of injuries that the patient is likely to have. Now, from there, after you receive your missed report, proceed and perform the primary survey. That is a priority. So if we are talking about you as the first responder, okay, you as the first responder, not necessarily you as the person receiving the report from the pre-hospital team, then you need to actually do your XABCDE. So this applies to the pre-hospital service provider as well as the initial responder. So if you're the first medic to come into contact with this patient, at times patients are evacuated by bystanders and they are brought to our facilities for care. So if you are the first responder, then you need to actually start by looking for any exsanguinating hemorrhage. So if you are the first point of contact as a medic, then you need to look for XABCDE, where the X refers to exsanguinating hemorrhage. So exsanguinating hemorrhage. Give me a sec. All right, so exsanguinating hemorrhage, we are saying this is hemorrhage that is likely to kill your patient within the first 2 to 3 minutes. So you need to be capable of identifying patients who are bleeding from an artery. So arterial bleeding, spotting, okay? So if there is exsanguinating hemorrhage, then what is it that you need to do for this patient? So the first thing that we can't write. Okay. So, yes, I would be able to write. All right. So give me a sec. Technology issues. Yes. So the first thing that we want to start with, if we have exsanguinating hemorrhage, is direct pressure, always. All right? So apply direct pressure if it is a compressible site. So when we say exsanguinating, this is external hemorrhage. This is hemorrhage that you can see, and it is significant. So you're the first medic to see this patient, and they have exsanguinating hemorrhage. Apply direct pressure. Now, if direct pressure does not resolve the bleeding, and we are talking about a limb, then proceed to do a tourniquet. I don't know whether that is the spelling of a tourniquet. I hope so, certainly. So if it's a limb or an extremity, then proceed to apply a tourniquet. Now we should have commercial tourniquets, but in case you do not have a commercial tourniquet, you can improvise, all right? The main aim is to stop that exsanguinating hemorrhage, because even with the fluids, you will not replace the oxygen carrying capacity of those red blood cells that are being lost. So the priority is to stop the hemorrhage. Now, once the hemorrhage is stopped, or if our patient does not have any exsanguinating hemorrhage, then you move to airway. Okay, this is slightly different when it comes to in hospital, because for in hospital, we are believing that the first responder who collected this patient from scene already managed the exsanguinating hemorrhage. And that's why the patient has made it to hospital. In most cases, patients with exsanguinating hemorrhage that is not controlled will not make it to hospital. So our in-hospital assessment often starts at airway. Okay, so airway, here we are talking about patency. So is the airway patent and is it safe? Okay, breathing comes next. So a compromised airway or compromised breathing will kill your patient next. Okay, so from exsanguinating hemorrhage, the next thing that is likely to kill your patient is a compromised airway or compromised breathing. We are going to discuss a bit more on that. So it's X for exsanguinating hemorrhage, airway, breathing, circulation, disability, then exposure or environment. So airway, we have already said patency and safety. Now, with some more time, we have 16 minutes. Wow. All right. So let us then focus on airway because of time. Okay. So because of time, I want us to then focus on airway. All right. But before we discuss airway management, your initial airway management, let us look at some of the things that you will do. So XABCDE is your sequence if you are the initial responder, with priority and emphasis being on exsanguinating hemorrhage. Okay. Now, if you are the first responder and you have stabilized the patient's XABCDE, then the next thing that you must do is you must triage this patient and determine whether or not your facility is capable of handling that patient. If not, you then need to determine where you are taking this patient. Okay, and this is where the field triage guidelines come in handy. Okay, the field triage guidelines help us categorize a patient very quickly as either a red patient or a yellow patient. Now, a red patient, you want to transport them to the highest level trauma center. So in this case, we want to transport them to the highest level of care, which would be a level 6. Okay, hopefully a level 7 if that actually comes to pass. A yellow patient we can transport to any trauma center as long as they have the surgical capacity to handle a trauma patient. So that yellow patient would be taken to such a center. The components that we consider are the mechanisms of injury. So the mechanism of injury, the injury patterns that the patient has, their mental status, as well as the vital signs that they have, as well as your judgment. So here we are saying EMS judgment, but remember, you are the first responder. So EMS or first responder judgment. So as the first responder, you will assess your patient and determine, where am I taking this patient? You have already done an initial assessment and management, your XABCDE. And we've said we are going to go into detail for today on A. Okay? So once you have stabilized those things, XABCDE, then you categorize your patient as red or yellow. A red patient is any patient who presents with penetrating injuries to the head, the neck, the torso, or the proximal extremities. So your humerus and your femur. Okay? So any patient who presents with those kind of injuries, that is a red patient, highest level trauma center or highest level of care. Any patient who presents to you with a skull deformity or a suspected skull fracture needs the highest level of care. Any patient in whom you suspect a spinal injury, and when you do your assessment at D, you find that they have new motor or sensory loss, that's a red patient. Any patient who presents with chest wall instability, okay, chest wall deformity, okay, chest wall paradoxical chest movement, as in flail chest, red patient. Suspected pelvic fracture. How will you suspect? When you're doing your E, your exposure, you will palpate the pelvis ever so slightly. If there is tenderness, pelvic tenderness, red patient. Any patient you suspect to have a fracture of the proximal long bones, suspected fracture of 2 or more of the proximal long bones. So a bilateral femur fracture, both humerus fractures, both humeral fractures, that's a red patient. Any patient who has a crushed, degloved, mangled, or pulseless extremity, red. Amputation that is above the level of the wrist or above the level of the ankle, red patient. Any patient who you have tried to manage through direct pressure and has required a tourniquet or requires wound packing with continuous pressure without relief, red patient. That is about the injury patterns. Now, if it comes to the mental status of the patient, any patient who you give a command and they cannot follow it, that is the motor component of the GCS, score less than 6, that's a red patient. Any patient who has an RR of 10 or an RR of above 29, meaning 30 and above, adult patient, that's a red patient because they need assisted ventilation. Any patient who is presenting in respiratory distress and requires respiratory support, red. Room air, pulse oximetry less than 90, red patient, following trauma. Now, any patient aged between 0 to 9 with a systolic blood pressure less than 70, plus 2 times the age. So this is the cutoff when it comes to determining whether your patient is hypotensive. Okay, so systolic blood pressure less than 70 plus 2 times the age. So if the age is say 4 years, so 4 times 2 is 8. So any patient presenting, a 4-year-old presenting with a systolic BP less than 78, red patient. 10 to 64 years of age, systolic BP less than 90, red patient. Heart rate greater than their systolic blood pressure. So you have a systolic of 87, heart rate of 150, or heart rate of 110, red patient. Any patient presenting aged above 65, presenting with a systolic less than 110, red patient. Again, heart rate heart rate greater than systolic blood pressure, red patient. Now, who is a yellow patient? Okay, so this is the next level of care. So level 5, yeah. So this is high risk. I won't go over them. Maybe I'll just go over the mechanism of injury. So high risk auto crash with partial or complete ejection. Even if they're stable, that's a yellow patient. If there was significant intrusion into this is more pre-hospital. If there's significant intrusion into the into the passenger compartment, let's say more than 12 inches or more than 18 inches on any side, yellow patient. If there was a death was reported in that very vehicle, yellow patient, even if that patient is stable. Any child who is age 0 to 9 and was unrestrained or unsecured, yellow patient. Now, if the patient has been involved in a crash at a speed that is significant, typically we say above about 60 kilometers per hour, okay? Or vehicle telemetry data that is consistent with severe injury, significant speeds, yellow patient. If the rider was separated from whatever they were riding on, if it's a motorbike, if at any point they were separated, that's a yellow patient, okay? A fall from height greater than 10 feet, all ages, anyone who falls from a height greater than 10 feet, that's a yellow patient. Additionally, there's your own judgment. So your own judgment can also determine whether you're sending the patient to the highest level of trauma or the next level of trauma. Now, I know over-triaging creates inefficiencies, but it's better to over-triage than under-triage. So from pre-hospital to in-hospital, one of the things that we need to ensure is effectively worked on is pre-notification, okay? So whichever facility you work in, if you receive a lot of trauma patients, insist on pre-notification. So EMS teams must pre-notify you of the kind of patient they are bringing to you. And they must give you the initial set of vital signs and the initial report. So we will look at what must be contained in that report, okay, so that you are able to prepare, okay, and you are able to prepare for your primary survey. Once the patient arrives, you do your primary survey and reevaluate. Once you've dealt with your ABCD, because primary survey is basically ABCDE, once you've dealt with that, you then reevaluate. If the patient is stable, you then proceed to your detailed secondary survey with reevaluation adjuncts. So these are your x-rays, your FAST, okay, or eFAST and the likes. Those are our reevaluation adjuncts, all right? Maybe CT, all right? So all those. And then, of course, reevaluation, and we then initiate definitive care. So this is in hospital, but it all starts with the pre-hospital team or you as a referring hospital calling the receiving facility and pre-notifying them of what has happened and what they should expect. What kind of patient are you sending to them? Good. Now, once we get to the facility or when we are reporting, we need to talk about the mechanism of injury. So that is MOI. So this is the missed report. Mechanism of injury, the kind of injuries that the patient has, the signs and symptoms that they are exhibiting, and their vital signs, okay? So signs and symptoms plus, signs and symptoms plus the vitals of the patient, as well as what has been done so far. This missed report then enables the receiving facility or you as the receiving practitioner to then prepare to care for this patient, all right? So reporting using the missed approach is very important. So mechanism of injury, the kind of injuries, the signs and symptoms and vitals, the treatments that have been initiated so far, okay? Once we have done the missed report, then we are now in hospital. Now in hospital, as we said, is airway, breathing, circulation, disability, and exposure. So this is where now I pick up the airway management presentation, and hopefully, so 3 minutes are not enough, maybe 10 minutes. So at airway, what should you do? So when it comes to airway, the first thing you must do is based on the mechanism of injury that you saw. You then assess whether there's a need for C-spine immobilization. If it is not already done, because it should have been done pre-hospital, so pre-hospital, your airway management is plus the need for C-spine immobilization. So if not already done, then C-spine immobilization or manual inline stabilization of the C-spine must be done. Once that is done, the next thing we do is to open the airway. So open the airway using positioning. That is assuming our patient is unresponsive. If your patient is responsive, then once we've done our manual inline stabilization, assess the airway by talking to your patient. You can say something like, "Good evening, sir. How are you doing?" All right. This will allow you to assess the patient's airway and their breathing. Okay. So airway with C-spine immobilization. Now, to discuss more on airway management, we are saying start with the basics. Remember, inadequate delivery of oxygenated blood to the brain and other vital organs will kill your patients quickest. Okay, apart from catastrophic hemorrhage, that is. A protected and obstructed airway and adequate ventilation are key to preventing hypoxia. Okay, securing a compromised airway, delivering oxygen and supporting ventilation take priority over everything else except for exsanguinating hemorrhage. So if they have exsanguinating hemorrhage, then that would be a priority. But that has been dealt with because we are in hospital. So secure the airway, deliver oxygen, and support ventilation. Okay? So the initial means of airway management, airway assessment, is to speak to the patient. So this will also allow you to determine the level of consciousness. "Hello, sir, can you hear me? Are you okay?" If they're able to speak and there are no added sounds, then likely their airway is not obstructed. And if they're not breathless, then likely their breathing is also adequate. Okay? Now, assessment should begin by looking for evidence of facial trauma. Okay? Because facial trauma or burns mean an imminent threat to your airway, even if it is patent right now. So if I likely suffered facial burns, then I suffered likely inhalation burns. So even though my airway might be patent right now and I'm speaking, it could get compromised with time. Okay, inspect the mouth for evidence of bleeding, vomitus, or broken or loose teeth, which happen to be some of the commonest causes of a compromised airway. So we are saying if the patient is unresponsive, then do positioning. How? Do a jaw thrust maneuver. Now, if a jaw thrust maneuver is not possible, another alternative could be the modified chin lift. These are skills, so possibly explaining them might not be possible, but you do a modified chin lift. You open that airway. Once you open that airway, check for bleeding, vomitus, broken or loose teeth. If we have bleeding, secretions, vomitus, then after positioning, the next thing you do is suctioning. So listen for noisy airway sounds or no airway sounds. If the patient is unresponsive, do a head tilt chin lift. If not all trauma patients will have suffered cervical spine injury. So if they haven't suffered or you don't suspect, based on the mechanism of injury, you don't suspect a cervical spine injury, do a head tilt chin lift. But if you suspect a cervical spine injury, do a jaw thrust. That is the preferred approach. It's preferred to a modified chin lift because a modified chin lift can still result in some neck movement. So do a jaw thrust to open the airway. If there are any secretions or obstructions, do away with them. So deal with any secretions or obstructions. So as we said, some of the commonest causes of airway compromise, if they have a decreased GCS, would be the tongue falling back. That should be relieved using your jaw thrust. Okay? Secretions, vomiters or blood, suctioning. Okay? Damaged facial structures. That's why we were looking to see if there's any facial injury. Damage to the airway structures, so your trachea and the likes. So a collapsed trachea could possibly cause airway compromise. Now, all trauma patients, if they are breathing adequately, meaning their respiratory rate is falling between 10 to 29, all trauma patients, once you achieve a patent airway, should be started on oxygen. Okay, so start them on oxygen, and as soon as possible, apply pulse oximetry. Now you start them on oxygen at the highest level. So you will start with a non-rebreather mask at 10 to 15 liters per minute. Okay, so start on oxygen, then apply your pulse oximetry. If your patient is saturating at 100%, titrate downwards. Okay, so determine how much oxygen they need to maintain adequate saturations of oxygen. But avoid hypoxemia at all times, by all means. Now, when it comes to your airway management, start simple, then move to complex, always. So start always with positioning. So when we say positioning, what we mean is your jaw thrust or head tilt, chin lift, if the patient does not have suspected C-spine injury. Now, if your jaw thrust fails, even if your patient has a suspected cervical spine injury, go ahead and do a head tilt chin lift, because a patent airway is more important than an intact cervical spine. Okay, so if you are unable to achieve a patent airway using your trauma maneuvers, your jaw thrust, your modified chin lift, your jaw tongue lift, all those, you are unable to achieve a patent airway, go ahead and do a head tilt chin lift. Now, after doing your head tilt chin lift or your jaw thrust or your positioning, consider the need for suctioning. When suctioning, we are saying do not suction for more than 15 seconds in the adult patient. Do not suction for more than 10 seconds in the child patient. So at any given time, if you need to suction for longer, pause, ensure you ventilate or they ventilate and adequately oxygenate before you then reattempt your suctioning. Okay, so you suction, after 15 seconds, you pause and allow them to reoxygenate. If it's an infant, then less than or equal to 5 seconds in terms of suctioning. Okay, 5 seconds. Okay, so for the infant. Once suctioning is done, we've said start simple to complex. Proceed to your airway adjunct, and this airway adjuncts, we are saying start with the basic airway adjuncts. So the basic airway adjuncts include your oropharyngeal and your nasopharyngeal airway. The oropharyngeal airway is inserted in a patient who does not have an intact gag reflex, and is not responsive. So unresponsive without an intact gag reflex. The OPA helps prevent the tongue from falling back and occluding the airway. All right? The sizing for the OPA is usually from the corner of the mouth to the angle of the jaw. Corner of the mouth to the angle of the jaw. The sizing for the NPA is from the tip of the nose to the earlobe. All right? And insertion for the NPA can be in a conscious, semi-conscious, or unconscious patient. It can be inserted in anyone with or without an intact gag reflex. The only contraindication to an NPA is if you suspect a base of skull fracture or a basal skull fracture. Then do not insert the NPA for risk of introducing it into the cranial vault. All right? Now, these basic airway adjuncts are your initial management. You then need to assess your patient, okay? If they need an advanced airway adjunct. So does my patient require an advanced airway? Okay, so who requires an advanced airway? We will look at that as we conclude. But we are saying the advanced airways include your supraglottic airway devices. So supraglottic airways. So it means we need to have these in stock. And the supraglottic airways include, so supraglottic, we are talking about advanced airway adjuncts. So supraglottic airways include your laryngeal mask airway, abbreviated LMA, your laryngeal tube, or the combi tube. Though the combi tube is no longer encouraged, its use is not as encouraged. So when it comes to supraglottic airways, the encouraged ones are the second generation. So you can go and find out more on what is a second generation supraglottic airway. Okay? These supraglottic airways are temporary. So even if you are unable to intubate, you don't have the skills or you don't have the equipment to intubate, you can as well insert a supraglottic airway. They are usually inserted blindly. So they are very good to have, particularly in our emergency departments, an LMA or a laryngeal tube. So that when there's airway compromise and we need to secure that airway, we can consider the supraglottic airways as we activate the specialized help that can then come and insert our definitive airways. So definitive airways, we are talking about your endotracheal tube or your tracheostomy if you are in hospital. So endotracheal tube or tracheostomy. If you are in a setting where tracheostomy is not possible and the patient's airway is severely threatened and there's upper airway compromise, perhaps facial structures have been damaged, jaw fractures or things like that, you are unable to manage the airway through the upper airway, then another possible consideration as a last resort can be a surgical airway. So an emergency surgical airway includes here a tracheostomy, but here we are talking more of a cricothyroidotomy. So a cricothyroidotomy, all right? So the cricothyroidotomy can be needle cricothyroidotomy, or it can be surgical cricothyroidotomy. So these are all possibilities that you consider in order to secure your airway. Remember, a patent airway is mandatory before you can do all the other things. So as we conclude, I want us to have a look at some of the skills we've mentioned. So we've mentioned a jaw thrust. I know we know how to do a head tilt chin lift, but do we know how to do a jaw thrust, for example? So allow me to just quickly get some presentation here so that we are able to then have a look. Edgar. On the Okay, so just give me a sec. I download it and then share. Okay, so let us start by looking at the jaw thrust, how you would do a jaw thrust. So if you suspect a cervical spine injury, this is how you would do a jaw thrust. So share, and then play. Play. So that's manual inline stabilization of the airway, of the cervical spine. So I know possibly it might be tricky to look at the videos and internalize. Yes, so 2-person, very good. So the lower fingers must be at the angle of the jaw. So the fingers go to the angle of the jaw and you displace the jaw forward, okay? You displace it upwards and that then moves or lifts the tongue along with it. Now, the other key skill that I want us to have a look at is the insertion of the basic airway adjuncts, the nasopharyngeal and then the oropharyngeal airway.
We use a nasopharyngeal airway when the patient is likely to not tolerate or gag on an oropharyngeal airway. First, assess the nasal passages for any obstruction, such as polyps, fractures, or hemorrhage. Select a proper-sized airway that will easily pass the selected nostril. Lubricate the nasopharyngeal airway with a water-soluble lubricant or tap water. Insert the tip of the airway into the nostril and direct it directly backwards and toward the patient's ear. Gently insert the nasopharyngeal airway through the nostril until the flange rests against the nostril. Once the airway is in place, ventilate the patient with a bag mask device if required.
Okay. When it comes to the oropharyngeal,
select the proper size airway. A correct sized airway extends from the corner of the patient's mouth to the external auditory canal. Insert a tongue blade on top of the patient's tongue, far enough back to compress the tongue adequately. Be careful not to cause the patient to gag. Insert the airway posteriorly, gently sliding the airway over the curvature of the tongue until the device's flange rests on top of the patient's lips. The airway must not push the tongue backward and block the airway. Remove the tongue blade and ventilate the patient with a bag mask device.
okay, there are variations to the oropharyngeal airway insertion, whereby you can basically turn it 180 degrees, but that is only in adults. In pediatric patients, as we have observed, use a tongue depressor. Now, bag mask ventilation is a skill that possibly I would want us to do practically for those who do enroll for the trauma courses. Another key airway adjunct, an advanced airway adjunct, is the laryngeal mask airway. So that is how it's inserted.
The balloon does not leak. Inflate and lubricate the cup. The patient's neck must not be overextended or hyperflexed. during the procedure. Hold the LMA with the dominant hand as you would a pen. Pass the LMA behind the upper incisors. Push the lubricated LMA into position along the palatopharyngeal curve, with the index finger maintaining pressure on the tube and guiding the LMA into the final position. Inflate the cuff with the correct volume of air as indicated on the shaft of the LMA. Check the placement of the tube by observing chest excursions with ventilation.
Okay, so those are advanced airway adjuncts, supraglottic. The laryngeal tube is also inserted similarly. Okay, so it's inserted similar to the LMA. Finally, we say surgical airways if you are unable to obtain a patent airway using your advanced airways such as the supraglottic and the laryngeal mask airway. So the cricothyrotomy can be needle, and this I think is the easiest to utilize and carries less risk, even though it's a stopgap measure. It's a temporary measure. So let me see.
To perform a needle cricothyroidotomy, you will need a 12 or 14 gauge over-the-needle catheter, a 6 to 12 milliliter syringe, and oxygen tubing connected to a source capable of delivering 50 pounds per square inch or greater at the nipple. Surgically prepare the neck using antiseptic swabs. Palpate the cricothyroid membrane anteriorly between the thyroid cartilage and cricoid cartilage. Stabilize the trachea with your thumb and forefinger. With the syringe attached to the needle, puncture the skin in the midline directly over the cricothyroid membrane. Direct the needle at a 45-degree angle caudally while applying negative pressure to the syringe. Carefully insert the needle through the lower half of the cricothyroid membrane, aspirating as the needle is advanced. Aspiration of air signifies entry into the tracheal lumen. Remove the syringe and withdraw the stylet while gently advancing the catheter downward into position. Take care not to perforate the posterior wall of the trachea. Attach the tubing over the catheter needle hub. Secure the catheter to the patient's neck and apply intermittent ventilation.
Okay, so you can see a needle cricothyrotomy is very narrow. It's a very tiny space. So ventilation will, without doubt, be affected. So you can't use this as a long-term airway measure. The one you can use as a long-term airway measure is a surgical cric, which again requires a lot of skill and a lot of training. Now, the surgical cric, similarly.
A surgical airway or cricothyroidotomy should be performed in traumatically injured patients who are A surgical airway or cricothyroidotomy should be performed in traumatically injured patients who are unable to be intubated either by oral or nasotracheal approaches. If the patient's condition allows, take the time to don a sterile gown and gloves, surgically prepare and drape the patient's neck, and locally anesthetize the planned incision. The appropriate landmarks should be identified to include the thyroid notch, the cricothyroid membrane at the bottom of the thyroid cartilage, and the sternal notch. A skin incision is made over the cricothyroid membrane, which is then inflexed transversely, taking care not to damage the cricoids or thyroid cartilages. The incision in the membrane is enlarged by gently inserting a tracheal spreader, knife handle, or hemostat into the wound, and spreading or rotating to open the airway. An appropriately sized, cuffed endotracheal or tracheostomy tube, usually a number 5 or 6, is inserted into the cricothyroid membrane incision, directly to distally into the trachea. Inflate the cuff and apply ventilation to the tube. Watch for chest excursion and auscultate the chest for evidence of adequate ventilation. Finally, secure the endotracheal or tracheostomy tube for the patient to prevent dislodging.
All right. So as I said, these are last resort measures. Now, if you are in an in-hospital setting where the capacity is there to do a tracheostomy, a proper one, then go with that, okay? So we are saying start simple, then to complex. So basic airway adjuncts, that means your oropharyngeal or your nasopharyngeal. Supraglottic airways are an option. Endotracheal tube, then tracheostomy, and you can then consider your cric as a last resort. I believe we are beyond time. I'm sorry. There's a lot to discuss, but hopefully when it comes to airway management, we are then able to manage our patients' airways better. The next time, hopefully we will be able to discuss how to confirm whether these airways are in the right place and how to go about it. I think we stop there.
Yeah.
Though I think I see Q&A. What about for a patient with a collar on? So for a patient with a collar on, if you need to do airway management and the collar is impeding your airway management, then you can take off the collar, do manual inline stabilization, and then insert your airway that you desire to insert. If the collar is not impeding, then you can possibly try, though most collars will impede, so take it off, then insert your airway management. Now, the soft collar is usually used for different applications, Martin. So Martin asked, do we apply the hard collar or the soft collar? The soft collar is used in particular applications when we need long-term cervical spine immobilization. The hard collar is typically what is used initially in your management of the patient. Let's stop there. I'll request Edgar to come and close for us. Sorry about the setup. It took a bit of our time, quite a bit, but hopefully the next one we will be able to take more time and do a lot more. So remember, A, B, C, D, E. So at airway, we've discussed. Hopefully next ones, we do breathing, circulation, and then disability and all that. Okay. Karibu, Edgar. Thank you, Flo.
All right. So thank you so much to Eric for a brilliantly done presentation. We have come to the end of today's presentation, essentially. I have shared links in the chat. In case you want to get in touch with us, please, you can do it via Instagram. You can do it via Facebook, text, WhatsApp, or call. Thank you so much for attending today. We hope to see you in the next one. We'll be having another one next week. Will we get CPD points for today's CME? Yes, we will. 8 CPD points for MOs, 4 CPD points for NOs, and 4 CPD points for CEOs. So tomorrow, I'll get in touch tomorrow morning regarding the methods on how to claim. For medical officers, I'll share there's a CPD claim card that you'll get where you'll input the code. For nursing officers, you'll get a certificate which you're supposed to upload online on the NCK portal. For clinical officers, unfortunately, we have not been we've not been able to be onboarded onto the online system. So you have to come physically to us with your logbook, and we'll stamp it and issue CPD points in that way. For paramedics, I will have to consult. Unfortunately, as we speak, we don't currently offer CPD points for paramedics. But the rest, tapata CPD points. I want to say a big thank you for attending once more. Just to share, maybe for those who missed out, these are the courses that we have. Let me see if I can get them. Sorry, I'm getting a terrible course on my end. Yes, so these are the other courses that we offer. We'll be having basic life support, advanced cardiac life support. We have currently one ongoing. The next one will be from 10th to 12th of April. Clinical ECG, in case you're interested, 10th of April. Pre-hospital trauma life support, where we talk more about trauma patients. Because the content is so much, it's impossible to cover it all in one CME. We hope you will attend the pre-hospital trauma life support course. Point of care ultrasound training. Deadline for booking is today. You can still make payment. I know it's late, but you can still make payment. Clinical ECG interpretation training, once more, we'll be having it in May, in case you missed the April one. And last but not least, we'll be having pediatric advanced life support in May as well. So we hope you will join us in these courses. We hope you will consider them. EMTs, you will get certificates as well. So paramedics, EMTs, tapata certificates. For location, this is where we're located, 5th Avenue Suites, 8th floor. This is along Gong Road, just before KNH. Just before KNH, 5th Avenue Suites, 8th floor at Quality Care. All right. So I'll get in touch tomorrow regarding CPD points via email. I want to say once more, thank you so much for attending the CME today. We'll be having at least one CME every week, one webinar. We'll also be having CMEs in various hospitals. In case you're working in a hospital and you'd want us to come and possibly talk about high quality CPR or management of trauma patients or stroke or ACS, we are very much willing and ready to do so. So please get in touch. For MOs, nitawatumia tu. I will send the CPD codes, then you'll be able to claim. Likely via WhatsApp, nitawatumia kwa WhatsApp, not via email. Contact is 0715-226-997. That is Edgar, Quality Care. That's me. Let me see if I can send it. All right, there we go. Yes, we have really tried. We keep on having challenges with the CO system, but we'll follow up with the board for COs once more, and hopefully it will be resolved. But I will confirm. Sawa. So having said all of that, see you in the next CME. In case you want us to come to your hospital, please get in touch via WhatsApp or call. Tutakuja tuongee juu ya high quality CPR, trauma life support, or any specific topic in emergency care that would be relevant to your facility that you'd want to be addressed. All right. So have a great Friday evening. See you in the next one. Oh, it's 07. Okay, sorry. Let me type it once more. Apologies, let me just type the number before we go. That's the one. Quality care. Yes, so I hope all our questions have been answered. BLS ACLS is 24,000 shillings. 24,000 certificates. All right. Have a great afternoon. In case of any additional, evening, in case of any additional questions, please WhatsApp me on the number provided. Have a great evening, guys. Goodbye.